You're listening to the Physio Matters podcast, this month in association with Staffordshire and Stoke-on-Trent Partnerships Physiotherapy and Orthopaedic Medicine Service, and this is session 17. Welcome back to the Physio Matters podcast with me, Jack Chew. An early plug for the ever-conscientious podcast team, Rob Tyre, Jack March, Richard Barnes, Charlotte Rattenbury and Paul Bibby. Enjoy their sharp wit and shameless promotions on their Twitter handle @TPM Podcast and on Facebook under the Physio Matters podcast. If you happen to have far too much time on your hands and want to hear more from me, I've been pretty busy working with the infamously noisy Adam Meakins, so look up my recent blog on his site, The Sports Physio, entitled So What Syndrome, and a guest appearance on Adam's latest medium, the NAF Physio podcast. Thanks as ever to those of you tuning in regularly, spreading the word and giving us constructive feedback on our episodes. We even recorded a response to Greg Lehman's session 16 with physiotherapist and PhD candidate Brad Neal, who had a few contrasting thoughts on lower limb biomechanics. We've put that chat onto our YouTube channel last week. Keep an eye and ear on there for exclusive content that should supplement our monthly offerings. So to session 17. We wanted to put something out there that was politically relevant around the time of the UK general election, but David Cameron wasn't keen. Russell Brand beat me to Ed Miliband, so instead we planned a podcast with a lesser known but much more interesting clinical lead of a musculoskeletal service. Paula Deacon from Staffordshire and Stoke-on-Trent Partnership NHS Trust, who have a Physiotherapy and Orthopaedic Medicine service, which is abbreviated throughout the podcast as POMS. Paula's very active across social media and she's often sharing stories of systems that they have in place, and quite frankly they all sounded a bit too good to be true, if I'm honest. So following the news that POMS had won a number of awards for their innovation and care quality, I did what my colleague Rob Tyre calls my best Louis Theroux impression, and I immersed myself within their service for a morning. I assure you all I did everything I could to unearth any team disharmony, any mistruths or any misrepresentations, and found very little to pick at. I'll summarise my experience at the end of the show, but for now, have a listen to what I consider to be a shining example of patient and staff-centred musculoskeletal care. Welcome to the Physio Matters podcast. Paula, would you like to introduce yourself for the listeners?
Yeah, thank you, Jack. My name's Paula Deacon, also known as Paula Woods 5 on Twitter. I'm a clinical lead physiotherapist in a physiotherapy and orthopaedic medicine service in Lichfield and Tamworth, based in the South Staffordshire and Stoke-on-Trent Partnership Trust.
And tell me a little bit about your clinical journey up to now then. How have you worked with yourself both within that service and anything else you do outside of that service?
Yeah, well, I qualified in 1996 from Bristol University, did some junior rotations down in Musgrove Park in Taunton, did some locum work in the Midlands, and then sort of specialised in MSK in 1999. I've been in the area ever since, and I've worked my way up to clinical leadership within a great team. I also work privately in the sports medicine element of it and work on the Senior European Tour Golf Tour, right. Where I do 3 tournaments a year with the golfers. Fantastic.
Pretty varied then.
Yep.
But today we're going to mainly talk about your POMS service, as it's acronymed. But at a time where the NHS is in the media for a lot of the wrong reasons, your MSK service is attracting attention and plaudits locally and nationally. Now, I'm sure during the course of our chat we're going to discuss many of the great things you guys are doing. But to start us off, what would you say, if I had to narrow it down to 3 key reasons that your service is thriving?
I think one of our unique selling point really is that care is our business, and care is the business of every member of this team, and that's not just clinicians, and that's down to the support staff, varying from Band 2 right up, to the most senior clinicians, which is myself as an 8A, and our sports and exercise medicine. So everyone is in this together really, and everybody cares about everybody's patients that come in the door. It's not just about your own patient really.
Right, okay.
So I think, we can drive the quality of that, and having clinical leadership and operational leadership is another unique unique thing of this service. We focus on the quality of the clinical application, and the team leader focuses on the operational side. And again, that's very unique in a lot of services that don't have that clinical leadership. It's very much driven by management. So our service is clinically led and operationally managed, and that has been a massive change in what we can deliver as clinicians.
Fantastic. And when did that as that occur? Was it a moment, or has it been something that's developed?
No, it started, in 2008, Lord Darcy report that stated that clinicians need to up their game, really, and clinical leadership was a massive thing. So our commissioners at the time in the PBC took that on board and funded for a clinical lead to run the service along with a medic, and that was in 2010. So 5.5 years we've been developing and leading and getting a culture within the organisation, within our service, to drive excellence of physiotherapy and MSK services.
Fantastic. And I'm sure we'll come to how that's sort of managed and split, and any problems even with that model that occur. Now, what would be the third thing of those then?
I think working closely, we've got brilliant relationships with our stakeholders. With our commissioners, we work so closely with them, and we have done over the course of 12 years, really. So we have a mutual respect for each other. They are very passionate about what we can deliver, and I think that relationship certainly drives what we can offer here, and they support that, and that allows us to challenge things a little bit clinically that maybe other services aren't doing.
So there's nothing stifling it from any angle, both on an operations level to the commissioning level, and at the front line you can get things done how you want them to be done.
Yeah. The organisation has a culture that empowers frontline staff. It empowers leadership at frontline level, which is absolutely where it needs to be, because we know what should happen, and all the great innovative ideas are from frontline leaders. And we're allowed to do that. Yeah, I mean, it comes within the quality framework, that making sure we're delivering a cost-effective, efficient service. But absolutely, it's about can we deliver what we need to deliver for our population.
Fantastic. The very first thing you said was about care being at the heart of everything that you guys do. And having immersed myself within the team today, and something that I will summarise, of course, is something that is evident throughout, and as you said, at every single level, and it works across the board. Now, some would argue, that, and I dare say we could just be devil's advocate in this circumstance and say, care is going to be at the heart of all healthcare, isn't it?
I think clinicians absolutely care. The thing is, I think a lot are stifled just by being in a whirlwind of wall-to-wall clinics. They don't have time to be creative. They don't have time to be innovative. What we do in POMS is we give them time. The staff of the NHS are absolutely the best asset. Well, you've got to invest in your staff. Happy staff. Happy patients.
So you nurture that flair and that innovation, and give that chance and afford them that time.
Yeah, to flourish, and to take ownership that they've been part of developing the service, not being dictated to of how we will deliver that. Is an absolute team approach, and everyone has a voice in that, and it doesn't really matter whether you're a band 3 or you're a band 8A. You have roles and responsibilities within that, band scale, but we're a family, we're a team.
Fantastic, and it really does resonate throughout your team that I've chatted to today. Now, before we go into the sort of chatting about the operational side and what sometimes what is it that stifles other services that you've been able to break free from, or maybe were never shackled by in the first place. Before we do that, let's talk a little bit about the intricate workings of your MSK team. So how are patients referred into POMS, and how does a patient's appropriateness for physio, how is it determined by their referrer, and then once the referral has been received?
Okay, so we're not purely a physiotherapy service. I think that's another big thing that's different. We used to be a separate MSK sort of MyCAT service, and then a physiotherapy service, and in 2010 we combined the two. So we are one big MSK service with physiotherapy being in it. So all MSK referrals come through our service. So that's from GP majority, 80% are GP referrals. We get some from other allied health professionals, and we get some from consultants from the acute trust. But majority of our work is from local GPs. So they all come through our service, unless there's red flags, and there's a pathway for that for GPs to refer, appropriately. So they come into our service, usually electronically through a choose and book system. An ESP will triage them to the most appropriate clinician. Now, that might be a sports and exercise medicine doctor, it might be an ESP, it might be one of the physios, and then they have to decide which band of physio.
Okay, and how's that then determined?
So we have a triage guideline. So our band 5s don't see any radicular patients, so whether that's upper limb or lower limb. They won't see anyone who has a history of depression. They won't see anybody who has got an unknown diagnosis. So we keep it very tight in their competencies. So only when they're competent to see a certain cohort of patients will they be allowed to see that cohort when they've had the appropriate training. Same with the band 6s, they see a certain cohort of patients. The ESPs see a certain cohort of patients, and so do the exercise and medicine. So rather than it being everyone comes through to a band 5 and it's look at the draw of, the jumping steps of the way, we try and get the patient to see the right clinician at the right time, who's got the right skills.
And there's a couple of things that I'll come back to on that and remind me if I forget to. But essentially, you're asking an awful lot of that referral. So I know in services that I've worked within myself is that you can get a referral that says neck and little else.
Yeah.
Now, apart from the fact that you just assume on professional respect that they have screened that and I think it's mechanical neck pain, but essentially you're not getting a lot to go off there.
No.
How have you made those referrals better?
Yeah, so I over the course, and we've been doing this triaging, I guess, for 12 years. So over the course, we've done a lot of educating of GPs and the importance that if they can inform us better, we can make better triaging decisions. So an example you just gave, Jack, of just neck pain with no other past history or no real story of that person's life, we reject that referral and we ask for more information.
And it's that steadfast rejection and the strength of your reasoning that really stands it in good stead. Because if you didn't do that, if you let them pass through now and again or
nothing would change. Nothing would change. The referrer wouldn't change their behaviour. So you've got to stand your ground and say, look, we want to deliver quality, but we can only do that if what we get in is quality. So our GPs are fantastic in this local area that they dictate letters. We don't have a pro forma that they tick a box to say just physiotherapy. We need more information to make sound clinical judgment on which band of team they are going to see.
And so once that's occurred, then I said I'd come back to it, and I have remembered. I understand why you do it like that way, because he's nurturing your junior staff. However, it is also somewhat protecting them from the real harsh reality of that waiting list. So how do you appropriately determine whether that's a useful thing for their development?
So for juniors, for example, certainly within the first year of them coming to POMS, if they're a new qualified graduate, they all have to do self-assessment competencies. So they will have go into the competency framework. Many of them haven't seen backs even undergraduate. It's not a given really. So they'll do a self-assessment. If they feel confident and competent that they have seen enough spines, brilliant, we will then do an observed assessment. So that'll be myself or my job share clinical lead who will assess their level of competency to make sure they're safe, to make sure they have the clinical reasoning skills and that they have the management skills. And only when they've passed that. And that might be 2 or 3 sessions, and we'll see some follow-ups and make sure the language is right. But we're happy that patient is seeing a great clinician. Fine, then they can see it.
Fantastic. So then essentially the band 5s don't see ridiculous symptoms. That's a standard. However, they would have chance to.
Oh, of course.
If they prove their competence, because it's a really common. The reason I jumped on that is because it's a sciatic driven pain would be something that is incredibly common. Therefore, to keep that from them might stifle their development, and then they became a band 6 having not seen that. That's not the case. What you're saying?
No, it's all fluent, but it's sort of a framework we start on, and some people move slowly through the competency framework, and some move really quickly, and that's fine. We're all different, and we all come in at very different levels and very different clinical reasoning. But absolute patient safety is absolutely paramount, and I won't have anybody just seeing anybody. They have to be of good calibre to see them.
Fantastic. No, and again, patience at the heart of it, and
Yeah.
trusting and empowering your staff, but also not just bundling everyone into categories.
No. So our band fives generally, we all know what it's like being a band five. There's so much to consolidate. You've just had a passport into the profession. You've had really very little clinical experience, 1,000 hours throughout your training. When I was a junior, you're thrown in and you just got anything off the waiting list. Was I a competent clinician? No. Are my staff a competent clinician? No, when they come in. Of course they're not. So they'll see the post-ops and they'll get competent doing the post-ops. Then they'll see the fractures as well, and they'll see a varied amount. But at the time they're learning their communication skills, at the same time they're learning their clinical reasoning skills, but still under a guidance of a protocol, for example, so they're not having to make too many, judgments that they're not feeling confident about. And that might be just for 3 months, because some of them might be absolutely brilliant and you're like, right, let's feed in some more. But they are absolutely supported that, and they tell us when they're ready. We have regular meetings and, how are you doing? What do we need to feed in now? And we feed in. Yeah, because you don't want to overwork them. You don't want them to be stressed. All these things that, we're all used to in the NHS. But actually, people then go off work. It just breaks down. So, no, we look after our staff and they look after our patients, and it's a win-win.
Happy days. No, that sounds great. Any problems with that historically or now?
There hasn't been really, because I think one of the problems would be the band sixes, who generally don't see as much post-op that they might have used to, or the total knee replacements, for example, because it's not cost effective for them to see that cohort of patients. So I think their caseload can be intense. They see a lot of chronic pain, they see a lot of non-specific diagnosis type patients, so the rehab is very individualised, and it's intense work. At the end of the day, you've got a full list of people like that you are almost taking ownership of their problem, really, and you're trying to make sense of it and then empowering them to do something about it, not to have any post-ops or total knees or fractured fingers in that day that we all like, because it's just like, I'm not going to think as hard, They don't have that. Yeah. So I think it's recognising that, we just need to support them and just make sure that they're not burning out, really.
Yeah, and then that's kept an eye on, and that's trained in a different way. And I'm sure as we're teeing up these things, we'll chat about that training ethos that you have underpinning your service.
Yeah.
Now, the key thing really that would be, dare I say, missing would be the self referral. That's not necessarily occurring as of now. What are your thoughts on that?
Yep. We spent. Last year we spent a day a month with NHS IQ and our commissioners working on the new model that we're working on at the minute to deliver an even better MSK service for our community. And self-referral was discussed, and it's certainly one option of an access in. I don't think it's the only option. There should be many ways in, and I think we could accommodate that. We have spoken to a number of patient groups, and the majority they don't know that they would want physio initially to begin with, unless the GP said, come in for physio. But there are then the young sports people who know they need to see a physio, and we don't have that option at the minute. Our commissioners don't commission a self-referral service, but I certainly think it's something, it's very focused in the media at the minute, isn't it? Karen Middleton was talking about it only the other day, and how it can save money. And I think at the forefront, if you get the right level of clinician, and for me personally in this area, if you want to do a good job, and it's not just about physio, it's about the MSK, what you're going to do with this MSK long-term condition, if you like. It's not always physiotherapy, it might be something else, or a health and well-being type approach. It's having maybe an ESP doing that role, in the GP practice, rather than, a band 5 or a band 6, which some GPs, I think, still think send them for physio and they'll do the ultrasound and the massage, and we've moved a long way from that, and our knowledge and skills in health and well-being are so much more better. We have a massive amounts to give, and I think self-referral to the right model,
So it is almost, because it is almost latched onto as this holy grail of all the answers, but clearly there's more to it than that.
Yeah, it's It just needs looking at very differently, and I think certainly our service, we're very innovative. We're always open to different ideas, as long as our patients can get in timely. That's the thing, getting access, reducing the wait along the way, reducing the administration that takes a lot of time. To see the right clinician. It has to be the right clinician, though. There's no point just putting a band 6 in who, isn't skilled in problem solving, isn't skilled in diagnostic, isn't skilled in all the orthopaedic type things, because then that patient's got to go to another level. They've got to go to another step. So it's like,
It's almost too obvious for an innovative service like this, isn't it, to just fall back on a self-referral that others are doing?
Yeah. And a lot of, we wouldn't do that.
No,
it would be a different type of approach, and we are looking at things like that in
It'd be
the
hard to police the standard of referral, I guess, as well. If you've managed to get the GPs working on a framework that understands the level of referral criteria, that'd be hard to police with Joe Public.
Yes, it would be, and it would destabilise us a little bit. It's not impossible. Nothing's impossible, is it? But I think it would destabilise the model and our efficiency of making sure that patient gets to the best clinician. Yeah.
Lovely. And although this podcast is going to be of massive clinical relevance to most listeners, I think some of the juiciest questions will be when we discuss things like finances, privatisation, staff management, and some of those sorts of things. But so before I delve into that, can we talk about the clinical frontline? We're both frontline clinicians, therefore let's go get us teeth into that. What clinical differences are there between your service and most other MSK services across the country?
I think the fact that we cross boundaries with our bandings, as an ESP myself, we sit within the service. We are open to discussion. We are on site every day to keep the patient journey going. So there's no putting onto another list and waiting, referring to another service. There's none of that. It's all, once the GP hands over their MSK patients to POMS, we either manage it in-house or we refer them to the most appropriate, whether that's the pain service, whether that's neurology, whether that's any other service. They sort of, it's our business to make a decision on what's best for them, and that's short-term and long-term. And the only time they go back to GP is with a plan.
Right, fantastic.
To manage it.
Now, to some extent, that is still pathway management, isn't it? To make sure they see the right person. But when they are in with your staff, and it's difficult because we don't want to build a straw man and tar every other MSK service with a certain brush. But what is it about your staff that are how are they interacting with patients differently to the average clinician across the country?
I mean, I haven't worked in many other services for a long time, but I have spoken to a lot of clinicians and done some talks and things, and it's just the ethos of that every patient gets almost what they need on the day. So if somebody is struggling a band 5, for example, and they need maybe considering an x-ray, there's an ESP around to actually clinically reason that, discuss it. The patient can go and have an x-ray because at our facilities, we've got them, lovely facilities. Patient comes up, x-ray done, decision made. And it's just, every patient is everyone's responsibility almost. It's like, it's not just your patient behind the curtain. If you're struggling, it's fine. Come out and speak to someone, but don't let the patient go without a plan. So it's just that culture that we have that, absolutely everybody, it doesn't matter that whether they see me or they see a band 5, only the fact that I can do different skills maybe, but that band 5 has the same skills in the toolkit. If they speak to me, their patient still has the right to have that.
Absolutely. No, that's really interesting that the curtains have been pulled down in a lot of ways in that sense. Now, another thing I've noticed from chatting to all levels of your staff today is that you're somewhat, comparatively to other services I've both worked within and also had the privilege of being invited to, is you're pretty forcibly evidence informed. Things need to be justified. Now, you're not scrutinising and pointing fingers and calling people out, but you're having people have to justify their clinical reasoning to some extent. How's that culture become prevalent?
Well, we have a lot of CPD time. I mean, we don't have a lot, but we do have this, and we're going to touch about it a bit more in detail. But it's just, I think when we first started on this journey, Clinicians were very much doing their own thing. There was no standardised care, even within the same service. There was no guidance, really. It was just a pick of the drawer on which clinician you saw, depending on what school of thought you were treated with. And then there'd be hot potatoed in between each clinician within the service, because you've obviously got the magic bullet that I don't have. And it was like, hang on a minute. I can't have a patient in the community when I see them in Tesco saying, oh yes, I had acupuncture when I came to your service, but if I'd have seen them, I'd have done some more exercise management. And you're like, well, can we get some, same page, please? So we started off looking with the Achilles, and had Peter Malaris come over and train the staff. We then all put in pathways and competencies and patient fact sheets. And it's sort of moved on from them, really. And we just have an open culture where it's non-threatening. It's just you are mentoring somebody, you're with the notes, and they have to go through their clinical reasoning. The ESP's been around and about. They have to have clinical reasoning to ask them why they want a diagnostic, for example. And that's every Wednesday morning from 9:30 till 10. The ESPs sit down with the staff and say, right, what's happening with your patients? And the pathways are no more than 3 treatments if they're not getting any better. And that means they're not getting any better. If they are, that's fine. They have to bring their notes to these meetings, and we have to critique them.
Yeah. But people aren't, the staff are far from threatened by that process.
Yeah, they're not threatened, no. I think in the past some might have been, and they're the ones that have left because they just, didn't like that, and, maybe the older school type physiotherapists. But since, we've replaced them and they're used to that culture, they come into that culture, they absolutely like it, I think. It's non-threatening. It's a value of, well, that's a training needs analysis, and we need to look at that and just put some training in place and support you. So actually, we're not having this conversation again next year.
Absolutely, no, for sure. Now, it's a collaborative patient empowerment model, and the flip side is that some people would feel that their autonomy is being threatened by this evidence-informed revolution that I'm, of course, a proponent of as well through this podcast. Now, you've mentioned that some people have opted to leave. Is that something that occurs a lot? Like, do you have to? Do some people feel like they can't forge their careers because they want to be more maverick-based?
No, we absolutely welcome inspiration. Anybody with any passion for anything is never stifled here. No way. The ones that, almost came along the journey with us, and it just wasn't for them. They just didn't like being challenged, really. And we had to challenge it to get the quality right. And I'm sorry if you can't join us, then, they decided to leave. And that, it's really sad to lose clinicians, but you replace them then with valued-based recruitment, and you get the right caliber staff who embrace the journey you're on, because you can't do it on your own. We're all in it together. So we want people who have got ideas and innovation and embrace all that.
Fantastic. Now, we know from an abundance of psychological and sociological evidence, as well as, we could say, combined life experience, that change comes slowly, and they say old habits die hard. Now, how do you at POMS manage a team of varying styles, special interests, belief systems, their experience levels? We've already touched on that, I agree, just with that last question, but how have you've instigated change that's way ahead of the trend in a lot of ways? There's some people only just starting a journey that you clearly have been doing for 10 years.
Yeah. There's been a lot of change in the organisation as well, and I think that's really helped support the clinical leadership. Again, that's not in abundance in our organisation, but certainly within POMS, having the support of the senior leadership has really helped, because they support your message really on the clinical floor. And that's seen throughout all levels of management. So it sort of makes it a bit easier that we've got this sort of appreciation and compassionate leadership within the organisation that, you've got an open door. So it does take time. Nothing's quick. And I think you have to get comfortable with that, and if you want to look at data from when you start something to 6 months down the line, forget it. You're looking at data 18 months down the line, really, just to keep, chipping away. You have to keep chipping away. If you put something in place and you don't keep monitoring, then it's pointless. So I think the joys of certainly my role is that I can keep monitoring, I can keep pushing. Come on, guys, patient reported outcome measures are a classic. How do you get a team of 36 to keep on with their outcomes? And we have to put in our sequence report because we flag it up. We constantly flag it up. Oh, you've not done your outcomes. Can you do them again? And if it's a case, then we've got our own supporting performance policy that, again, before we bring in the trust one, we can support our own staff and say, why is it? Have you not got enough time to do it?
Yeah.
Is there a different way we can do it? Can the admin give it out then at reception before they come in? As a team, there's no blame. There's like, well, why aren't you doing it? What can we do to help you? And then they're done. And then you see a change in behaviour.
And that's how your quality is measured on that. It's not a dictatorship. Not I'm saying you as a dictator, but I mean there's no one at the top saying this is how I think it should be done.
No.
It is democratic, and it is also something that is justified because of the quality that you all thrive for and you're all proud of, essentially.
Yeah. Again, I quite like keep pushing the boundaries, really, just so we can underpin the service with better training if we need it, and just if an area that we're really failing down on. So we decided to audit 6 months, patients who were discharged at 6 months on their outcomes, and that was looking at whether they'd had to go back to see their GP for the same thing, whether they'd had to see another health professional for the same thing, and if they had, who had they seen, whether that be a consultant, osteopath, chiro, private physio. We did a year's worth of data looking at the outcomes, and I think it was 76% or something like that hadn't had to go back to their GP. They were self-managing very well. A small proportion had gone back. Mainly low back pain was the cohort of patients, which again we're looking at that now and making sure we try and improve that data. But it's not just about the here and now, and once you leave our doors we're not really interested. We are interested because actually what we do is impacting on their health journey, so we've got to get it as best we can right at primary care.
Because people coming back into the system is exactly not what you're trying to perpetuate. As a business model, some would argue it's brilliant. However, you're wanting to try to empower long-term health in these people and then measuring yourself on how you do that.
Yeah.
Okay.
Yeah.
Fantastic. No, that's brilliant. Now, it seems that training and education are central to your model of care. So what is the format of your peer support network, and does it vary across the pay grades?
So all staff have Wednesday morning at the moment, and they've had this throughout the 5 years, is CPD time. So they down tools till 12 o'clock to do specific things. It is monitored though, and within that time they have to do their mentoring, they'll have service development to do, they will have patients to discuss. So it's all very structured in a roundabout way, and they'll have service development that sort of takes lead on that. So they'll do projects, whether, we've just done lateral hip pain, we've got lateral epicondylopathy coming up, we've just done patellofemoral pain as well. So they'll all have topics that they're working on, and that will be across bands doing it. So a band 7 might support the band 5 and the band 6 is doing it. So they've all got the same amount of time. What they do in that will vary because, they'll have ESP meetings to go to, they'll have their band 5 or 6 meetings to go to. So as a supportive peer support, there's a varied amount of activity within that time. And that CPD time is fluent as well. So if they want to go and do an external course, for example, fine, but they'll have to put that time back in somewhere else. So they'll use that CPD time on another day, but they can put it back in clinically somewhere else. Do you see what I mean? So it's win-win. Everyone's happy. They're supported. They've got time to learn. They've got time to flourish. We can listen to their innovations. We have twice a year MSK forums. So we hear, right, okay, guys, this is where we're at. Anything we need to change? Anyone's got any ideas? How's that going to benefit the patients? How's that going to benefit the service? How's it going to be more cost effective doing it like that? And we just brainstorm it. Having time out once a week to regroup. We have away days twice a year. It's just, having that great value that you walk in the door and you're proud and, you want to do the best you can for every hour that you're here. Their heads are not just down in the sand every day. They really have time to have time to think, where are we at, what could I do better? They reflect themselves. They have to hand in a monthly sheet. I have to know, I've got a database that we keep track of, their learning. So every month they have to put in their monthly sheets on what they've been doing on every Wednesday, so I can see, someone's learning this, or that's interesting, maybe so-and-so would like to do that, can you just carry over, so it's all tight. It's not just, people might think it's a luxury. I'd say it's absolutely necessary, and everyone should be striving for it as a profession. Our medical staff, they have protected CPD time. Why shouldn't we?
Absolutely. No, that makes total sense.
What we don't encourage is really just purely individual learning. That was the thing about the training, is that we encourage lots of learning, but we don't, it has to be specific for our patient cohort. So if someone wants to go off and do a master's, we'd have to just think about that a little bit, on what that would benefit the service rather than them just as an individual. So I think that might be a bit different to how other people do their training.
Where it sort of could fall down in other services is if things are more strung out. So is that something you would consider to be a threat to that? If, say, suddenly it's not going to happen, but if your service was to say, right, I'm going to take all your staff and spread them out across the city, and you'd have to then get them back together for that Wednesday morning, you'd still feel that would be of value, and you'd still manage it that way?
It's absolutely... I mean, all the staff, if you spoke to them, would say, it's absolutely invaluable, because we see how it impacts on patient care. You can't just keep
in fairness, that's exactly what they have said to me today. Hopefully they haven't been primed to do so.
I need to pay them all later.
That's one of the first things that they came up with, really, is just how much they value that time.
Yeah, it's a real way of everyone just having time to discuss best practice, what they're struggling with. Yeah, their mentorship, their clinical supervision. Our organisation has put a formal policy together that all staff in the organisation have to have a minimum of an hour a month with a clinical supervisor. So, there are some things in place, but an hour a month's not very much for what we'd need to do. So it's sort of digging your heels in and saying, well, you've got to invest in your staff. If you don't invest in your staff, the turnaround's quick, they move on. You can grow your own. You really can grow your own staff, and they will develop and become great clinicians in the future, and we all just move up, and maybe I don't know if I'll ever retire, but, everyone's empowered because we allow them to, but it's not at the cost. It's not at the cost of patient care. It absolutely supports patient care.
Fantastic, yeah, and I think that's what people worry about, isn't it? If people are given that rope or that leeway to learn and develop, that would actually be at the detriment of patient mileage, which is just not true.
It's not true. We wouldn't have won the 6 C's award. We wouldn't have won Outstanding Team of the Year if we didn't have that time to flourish. There is absolutely no doubt about it, because you haven't got time. Who's got time to develop all them fact sheets you've seen? Who's got time to do that? Well, they could do it in their own time, but that's not really fair.
No, but in some services that is what is expected, which is another shame. And there is a burnout problem that does occur across all different sectors.
Yeah.
Now, one of the things I want to question is you've mentioned the ESP framework that you have, which will be different to some services, and we can't make direct comparisons. But you're talking about ESP integration as being, and you have an ESP hat that you wear, and I've spent this morning with you, saw a young lady with back pain that was come from a consultant referral. Now, that's different to other ESP roles, which are purely a triage-based thing that is done remotely almost, and there's no contact, but there's a big disconnect between an ESP role and a clinical frontline. Yeah. Now, what are your thoughts on those two things? What you do, and also how others, or most, I would say, do?
Yeah, I think. Again, that's very common to have ESP separate to physios, and ESPs are physios, and I think what happens is majority. And I haven't got the data to prove this, but I think majority of services like MyCats or integrated MSK services who aren't with the physios, they do refer a lot to physio. And then the problem is, I think, is that the quality of physio may not be challenged because there's no one driving that two-way conversation. Yeah. So again, they have physio, and if that fails, they're bounced back to the ESP, and the ESP's powerless, and they might inject or they might get diagnostics. But actually, if you're in the hub of it, driving the quality, you don't need that. ESPs for me is get back into clinic, get back in with your physios. This is where you can triage as well, because we do that. We triage as well, but we keep the patient journey moving quickly, and we empower the team and we educate the team, and
that challenges your learning as well. First and foremost, because sometimes maybe ESP networks are only self-supported by other ESPs rather than from the others coming up and biting at their heels, shall we say?
Oh gosh, yeah, and it's a challenge, but I think ESP sitting independently of physiotherapy services, I don't feel that's the right way to go. I think they need to come in. They've got a wealth of knowledge. They could be clinical leaders themselves, like myself, driving the quality forward and just missing out that wait time for the patient. Just deal with it on the day. Let's have a conversation about it. Actually, have you thought about doing this with that patient? Oh, no, I hadn't thought about that, right? Just do that, and then next Wednesday we'll have a clinical reasoning discussion about it, so we'll tie it up.
Yeah, and I think that's a common statement that you've said is let's talk about it. It's something that you will like to discuss. It's not about right and wrong. It's about, well, why? Let's talk about that. And that's brilliant. Now I'm going to be awkward and provocative and suggest that why is it that these models of care do exist and are steadfastly stuck to with ESPs? Why is it that there is a disconnect? Why do some people seem to crave that next step and distance themselves from what used to be their frontline duty?
Yeah, I don't know. I just think it's the models, and again, once you're in any model, if you've not got time to think about it, you just keep doing the same old, and it's like, can we just look at things differently, which is what we do in POMS. We just think, hang on a minute, can't we make this a bit more streamlined for the patient? So we do it.
Do we sometimes find that as part of a physiotherapy hierarchy, are we almost going primitively back to a model where a physio will constantly strive to work up a ladder and then eventually start to reason medically? Because it's like chasing a doctor's tail almost.
Yeah.
Even though we make all this noise about being autonomous, essentially we're just hoping to be a poor man's registrar that's underpaid.
Yeah, I think there is some of that. And I think certainly in primary care, ESP is very different to an ESP in secondary care. And I think they are, like a registrar role. For me, ESP should be in primary care. This is where our biggest value is. I think this is where we can save so much money. If we get it right in primary care, most patients won't hit secondary care. Or if they do, they'll get there a lot quicker. And that's fine. Yeah. Let's not increase chronicity. Let's not drive them down a model that's the wrong path. And I think this is where ESPs absolutely have their wealth, and that's what our commissioners see, and that's why we're expanding our ESP team, which is fantastic.
And once again, all measured and quality assessed.
Yeah.
So this question was bound to come, Paula. We need to talk about privatisation of the NHS. Let's start with a few pros and cons, if you can.
I think the pros...
this will be quick.
We'll be really quick. I think from a positive point of view, I think it has made the NHS get a bit more business savvy. So I think it's made the whole of the organisation look at its business model a bit more, so we can justify taxpayers' money. We can justify, that why we're worth our value. Other pros of privatisation. I'm struggling there, Jack, actually.
Yeah.
Any thoughts yourself?
We've topped out at one. Oh, brilliant. No, I'd certainly agree with your first point there, and I think there are other elements lacking. I think that the way in which the private sector serves to market itself, I'm not a big fan of that, and I don't attach myself to it, but they certainly... They oversell and the NHS undersells, and I would say that it's somewhere in the middle that can be found. That's not morally backward, but still champions itself better. So that's one thing that can be learned. But no, I do agree. They're a bit slim pickings on the pros. So let's talk about the cons.
I think the cons, and I've sort of seen it firsthand, really, when I was fortunate to project manage a pain service that got decommissioned from a private provider. And it was very intervention-led. It was very passive treatment. It was very dependent on people needing treatment rather than sort of the NHS model, which is empowering patients to self-manage and take control of their health. And a bit of selling sickness, a bit of, we want you to be unwell because we want you to keep coming back. So it's sort of almost
whether on
the opposite.
purpose or accidental, they need people to be unwell.
Yeah. So it's sort of the opposite end of the scale to what we're delivering, really. So it doesn't sit comfortable with me at all. And I work privately, but my private practice is the same as the NHS. Patients get absolutely the same care.
And it is very, very few clinicians that can hand on heart say that. So what challenges have you had when trying to roll out your personal clinical ethos in a current private setting?
Well, fortunately, it's not my own private business, so it's not my job that pays the mortgage, so I suppose it's a bit different. I rely on my reputation more than anything, and, if I see somebody once or twice and they tell their friend that, go and see Paula, that means more to me than the same person coming back 5 or 6 times. And the local GPs, for me, fortunately appreciate that and send their patients to me. So I'm quite fortunate that I'm well established in the area that, my values absolutely, I won't lower my ceiling for, regardless whether it's private or NHS. It's the same, absolutely the same.
And so profit-driven healthcare is something that you consider to be... it's a genuine threat. I think we all recognise that, but locally you feel that what POMS has done stands it in good stead. Good luck to anyone that wants to come and try and snoop around privately, because they'd struggle to match you.
They would struggle because of our, and we've got, we're quite well established as well locally, and...
reputation counts for a lot. You mentioned
more
it
than
personally,
anything, really.
but also your reputation now as
a
a
service. Absolutely. It's being proud. I want to be proud. I want to be proud that I can walk in my community with my head held high and know that if they've been in our service, they've had the best of the best, absolutely, without a shadow of a doubt. And if they haven't, then it's my job to make sure they do get the best of the best. So
constantly striving for better.
Oh, constantly, constantly.
Fantastic. Well, you've skirted that. That was one of my harder questions, so you've skirted that fantastically. And although we can't tar everyone with the same brush, have NHS services and the staff that work within them brought it on themselves to some extent? And by it, I mean privatisation. What's opened the door?
I just think there's a lot of same old in the NHS. I think, like the NHS, like Simon Stevens says, the CEO of NHS England, we cannot continue delivering care the way we've been delivering it. And the NHS, I feel, relies on same old. Because people haven't got time to be innovative, and that needs to come from the front line. It can't come from middle management. It can't come from senior management. It has to be driven frontline staff, and that needs leadership to drive that, to keep that motivation, that innovation, that passion. Hence, I think why POMS is so successful. And people want to come and work here, and it's lovely, it's fantastic.
Because I completely agree, but it is a diplomatic way of looking at it, that it's just the time. Is there some change-averse nature of some people that keep their head down and cross their fingers that it will go away?
Sure there are, and I think, I just think we've got to embrace change. And I think certainly in MSK physiotherapy services, carrying on for another 10 years stuck behind curtains doing the same old, private companies will see that and they'll be innovative. They will be doing the health and wellbeing stuff.
And they'll leach the staff that have that propensity, I guess, if we're not careful.
Yeah, pushing the boundaries a little bit, changing the models, being creative. There's no barriers to it, really. You've got to look at the safety of it and the logistics, but just thinking differently. And when we've got to look at prevention and we've got to look at long-term MSK conditions, managing it better, coming into a clinic to see someone behind a curtain isn't always the best way. I think it's, utilising other other professionals, whether that be the fitness, our fitness colleagues, or anything, just different exercise.
Yeah.
There's a wealth of knowledge out there, isn't there, that we become siloed, really.
I mean, feel free to disagree with me, but it seems pretty clear from our chat today, our previous interactions on Twitter, and what I've come to understand, especially with immersing myself within your team this morning, is that it is a very staff-centred management, both in you personally and also the other managers that I've met today. And that then makes people patient-centred as clinicians.
Yeah.
So tell me a little bit about that and how you manage your staff and what real pivotal parts of that process stand POMS in great stead.
Recruitment is key. I felt a lot of the traditional ways of interviewing didn't really make you understand the person, and I think values can't be learnt. I think you've either got the values or you haven't. So we recruit people of a certain calibre, I guess, with their values. So we do have value-based recruitment questions that our organisation have recently put in place, and to make sure we focus on people, make sure we focus on quality, make sure we take responsibility. So we do have very specific types of questions that really pull out. But even before they were put in place, I'd write my questions to get to the heart of the person. Not just their clinical skills, because we can train them. We can support them. We can facilitate their learning through competency and training needs analysis. But I want to know them. What makes them tick? What are their values? Would they raise concerns? What is a concern? I just want to understand someone's ethos, really.
What makes them tick
what
rather
makes
than
them
their
tick.
Specific skill set.
Yeah.
Now, the skills are, of course,
skills are
helpful.
important.
Yeah.
Skills are important, and that comes on your person's spec. So when you shortlist, and that's all it is, though. Once they're in, they're grilled on them, really, and not grilled in a negative way. Just, I'm really genuinely interested.
Yeah.
What was your dissertation? Why did you choose that? I'm really interested to understand why you felt that, and how's that carried over into your practice, and what have you done about that? And was that just for you, or actually did you do it for a team? Because people who are just me generally don't get in.
Fantastic, right.
Because we are a team.
Exactly, you are. Now, it's intriguing. I'm glad you brought recruitment up, because chatting to all bands from administrative duties through to your core managers and your operational managers that I've chatted to today, it keeps coming up, recruitment. Now, I expected sort of you to mention recruitment. Now, I didn't expect your band 4s and 5s to mention recruitment, but they're really proud of the people that come in to work as their colleagues.
Yeah,
they
but
trust the system.
Well, they're on the panel. We always have a peer. In the interview. So if we're recruiting a band 3, Emma, our band 4, will be on the interview panel, because they've got to work with them. They've got to bond with them. Their decision is as important as mine as their leader. So regardless of what band, we will have a peer on the interview panel. And operationally, we don't generally have an operational manager interviewing. It's purely clinically led. So they have to be, their peers have to be happy with them, and we have to be happy with them, because we've got to lead
pride
them.
in the system, pride in the recruitment, and therefore they're confident that when a new member of staff comes in, they're going to be
they
integrated
embrace
really
it.
well.
Yeah. And then they'll have a period of support. They will have an induction time. They'll have objectives set. So again, it's very fluent, but they're in it for the long haul. We don't want a high turnaround of staff. They're within the team very quickly, and they will absolutely contribute. Their voice is valid, and we want to hear it.
They'd feel comfortable to contribute. They'd hit the ground running pretty quickly, wouldn't they, through the competency frameworks, etc. Now, that is very different, I would say, to public sector interviewing, full stop. I've got a lot of friends of mine that are teachers. They work on a points-based system. I've been on both sides of the table of points-based, objectified NHS interviews, where we've both been on a panel.
They are point-based. But
they're not a stringent mark scheme.
No, between 1 to 5, and you can weight them depending on their importance. I'd say they're all important. So for me, they've all got the same weighting. You can't ask a question that's not as valid as another one, really. So, and people answer questions very differently personally about their reflection of themselves very differently, and that's when you get out the real value of a person. And
So you're teasing out that meaty value that someone offers as a person, not necessarily just the bare bones of them reeling off their CV.
No.
Okay. No, really interesting stuff. Now, how do you, once you've got them, how are you keeping and we've touched on a few things, of course, already. How are you keeping them motivated in light of things like budget cuts, this NHS media pressure that gets given, and the downsides that come with some people not always being as NHS proud as say you or I. Now, how do you keep them ticking and keep that quality high?
Yeah. So again, the time out on a Wednesday morning is a great time for support. Take an interest in people. We all like to be made to feel like someone's interested, don't we? So I think that's really vital that you meet with them regularly, whether that's myself or whether that's their mentor. Every member of staff has a mentor. That they know that they're valued in this team, and what they say is valid, and we're here to support them, to make them safer and better for their patients. So it sort of keeps motivating themselves because they see the culture, they want to be part of that, they want to drive forward innovation. So we just give them the time to do that.
Your admin staff and your secretarial staff and even let's say as well your clinical but unqualified staff, from what I've talked about, they consider themselves valued, but they strive to help each other so much. How can I make your job easier?
Oh, yeah.
And so they feel part of that clinical front line themselves. So I've never known a receptionist, for example, that recognises just how much they impact on patient care.
Oh gosh, yeah.
And that's what's intriguing, is you really are intertwined and very genuinely horizontally learning from each other.
Oh yeah, and we're just a team. And that's giving out trade secrets. But, I always like to ask people, what does team mean to you? It is about shared values. It's about a shared vision. It's about everyone is in this together. Leave your ego at the door. When you're in here, you put on your jacket, and we're like family.
Yeah.
And if someone's struggling, having a bad day, and you've got a bit of time out, maybe could you just unload them a little bit, or go and help out on reception? We're just not setting our own job description, actually, we just got to keep this service running. Let's
Absolutely.
just keep it going.
Yeah, and I hope this, and I'm sure it won't, that this podcast shouldn't come across as one big glorified advert, as much as I have been bought in and won over by this process I've been in today. But to talk about that then, we are holding you up as a shining light, and I would stand by that from today.
Oh, thank
now,
you.
Our services such as yours, and I dare say ideologies such as yours, if I want to call it that, and I don't like to call it that, but this concept is very pure. Now, are they supported enough from higher authorities and governing bodies? Because I'm here championing it as best I can on my little podcast platform. Now, is that then taken further, in your opinion?
Well, I think you just got to keep shouting, and we're very vocal. The CSP are going to run our Outstanding Team of the Year award in Frontline next month. So, we're just chipping away, and I get out to conferences, I do speak, I do talks, and I share all our competencies. I'm very happy to share anything at all. But I think, there's always the political drive of, what's focusing at the minute, which is self-referral, I think, is on the agenda. And, I don't know if it is supported. I don't know, physiotherapists, we could be a bit louder.
Yeah.
Like Karen Middleton will say, we've got to get in there and drive forward. And I think in a lot of services, and I'm sure many frontline clinicians will agree with me, it's hard because the operational management is closing the door on that. How do you get past that?
Yeah.
I interviewed yesterday, and you see stifled clinicians who are great clinicians, innovative clinicians, and in our environment they would thrive, but they're not in an organisation that's got that culture, and it's hard as an AHP group who are stifled down to get out of that.
Yeah.
But we're doing it. We're getting out. We're chipping away and flying the flag for physio and AHPs, and I think that's all you can do. But I don't know if higher level. Certainly in our organisation, they're seeing the value of clinical leadership, which is what I'm very focused on, and I know the the benefits of clinical leadership, and I'm sure my team, they can see the benefits
And your
of clinical
operations
leadership.
team is telling me all day about the fact that they're really into the clinical leadership, because I was trying to coax out whether there was any locking of horns that goes on, but it just doesn't sound like that.
No. I mean, they can get on with their job. They're so focused, and, I couldn't do my job without their absolute support. They do a fantastic operational job.
Okay.
And we do the clinical, and together, what a great combination.
Absolutely. Now, the key thing really is, though, if we all as physios could be louder, and I agree with that, and I champion that. That's why I try and put people behind sodding microphones, I guess. But essentially, if one service is doing a really good thing well and promoting quality, patient empowerment, evidence-informed practice, and that's being loud and championed. Now, if another service is doing fundamentally their general day-to-day stuff isn't particularly impressive on those same quality values, yet they are being loud and being championing themselves within their local community, does that not detract? Because we do get tired with the same brush, physiotherapy being physiotherapy. So if we just champion physiotherapy, whatever it may be, can that not just quash the good message that is coming out of things like POMS?
We're not really monitored, are we? We're not really clinically monitored. Nobody's coming in and doing audits on our practice. No one's coming in scrutinising, what are we delivering? And we certainly do in POMS, and that's what the clinical leadership is about, is monitoring that value, and that's evidence-based practice. But is that happening elsewhere? We've not got anyone like Ofsted coming in, have we? And checking out what's happening on a day-to-day basis. And I think that would be a useful thing, because that's how you see what's going on, really, rather than just patient-related outcomes. And what's happening 6 months down the line, which is an audit we did, what are happening to our patients? We're getting great outcomes. It's 2 or 3 weeks that they've finished their treatments, or 6 weeks, whatever. Yeah, but what's happening to them on a greater health economy 6 months after we've seen them?
And is POMS proof that wider ethos can be done without it being Big Brother? The patient's care is being justified, but it's not being these clinicians don't feel threatened. Now, essentially, if we had an Ofsted or say the CQC started to scrutinise quality and a more evidence-based approach, the worry would be that it'd be an us and them. It'd be, we're doing it this way and this is the way to do it, and it would strip back autonomy. That needn't be the case, and you're proof of that.
No, and we all know, one size doesn't fit all for patients, and you've got to be able to justify, why did that patient go down that pathway? And I think as a profession, we should hold ourselves to account to that. We should absolutely be able to justify, not only in a court of law, when we're up to, when there's been a problem, but we should be able to justify that for every single patient we see.
It's a clinical reasoning at the heart of everything.
Absolutely.
And that's the message that we want to try and deliver with this podcast, is just to show people that everything that some people would consider to be false, idealistic values in some ways, are being done, and it can be done given the right opportunities. To sum things up then, Paula, unless there's a massive gap in what we've missed, is there anything you'd like to plug, anyone you'd like to thank?
I just think, I'm very biased in our organisation, but the support of the executive team is fantastic. It's a culture that drives clinical excellence. The values of our organisation are putting the patient at the heart of it. Just makes our job easier at the front line. But I would just strongly encourage every clinician out there to have a voice and have the balls to do something about it. Don't sit down and be quiet. And that's what I'd encourage.
Loudness.
Be loud. Be challenging, and you can do it, but it's hard if you haven't got clinical leadership to strive in that, and it's more operationally led. Because it's KPIs, it's targets, where that's all really important, and we have to be very aware of that. But there's ways you can do it more efficiently and more effectively. And the clinicians will have the ideas. They work in it every day.
Absolutely.
You just got to listen.
You'll listen to them, of course, and have the ability to act and the confidence to act on it.
Yeah.
So that's great. So I thank you so much for your time. Thanks to your team for having me as well.
No, it's been a pleasure.
It's been great, and I look forward to getting this out there.
Thanks, Jack. Cheers.
So there you have session 17. Massive thanks to Paula and all the team at POMS Lichfield. They were all incredibly welcoming, as well as open and honest when presented with some pretty awkward questions even by my standards. I chatted to physios of all pay grades, clinical assistants, admin staff, operations managers, and even a student. Basically anyone who would A, humour me pretending to be a journalist for 10 minutes, and B, whoever I thought might be able to help me burst what seemed a pretty idealistic bubble at the time. Now, they're either all incredible actors or they genuinely don't have anything to hide. I'm not for a minute suggesting that POMS is the perfect service, but having worked in several myself of varying standards, they are the best I've come across. The most interesting insights for me, though, came when I was shadowing the therapists. For a couple of patients, I was in on the assessment, but also on occasions I simply happened to be in earshot through curtains. The reason that these moments were particularly valuable is because the POMS team do not pay lip service to their evidence-based service improvements like some services do. There's a culture of justifying your reasoning, and as Paula explained, it's non-threatening and it's supported with training and mentorship, which make the staff really value the fact that they want to scrutinise their own and each other's practice. The clinical quality is therefore high across the board, but the consistency of the message doesn't compromise or seem to compromise the individual subspecialisms or the creative flair that you want within a department. So it's fair to say I'm a fan, and I hope you are too. I'm well aware that you regular listeners are seriously progressive smart cookies and that we're often preaching to the converted. But if you want change and regularly find yourself frustrated by the service level inefficiencies, get brave, shout louder. Use this episode as a resource. Try it as an in-service training. Smuggle it onto your manager's desktop or phone and feel empowered by the fact that these guys are proving that it can be done. For any further guidance, contact Paula through the Choose Health Network or find her on Twitter at PaulaWoods5. The show notes newsletter has had a recent subscriber boost. Find the sign-up page at the very bottom of the podcast page of our website. And finally, after a month without it, the cheesy sign-out is back. You've been listening to the Physio Matters podcast, discussing physio matters because physio matters. Bye for now.